Hello and welcome.
Can you see,
Absolutely wonderful. I
can
can
you
see you and can hear you.
can you see the slides, Henry?
Not as yet. We were going to do chit chat.
Can you see
and
Oh, there we go. That's absolutely fine. That's absolutely fine.
we, we don't need to. You can just throw me out. Throw me out. I'm on a lot, so like people are kind of used to me. No, like you heard me talk. Like you're amazing,
Oh,
and
thank you, Henry.
something that when we spoke about this, the passion and desire to make these points was so fervent from you. It was honestly, it was like a shining flame of wonderfulness, and I warmed my soul. It was beautiful. Right, shall I share the slides? You'll get on with it because I know
That's
I've
right.
seen the slides. You've got a lot to get through because you're here to make a point.
Thank you, Henry. So, welcome everybody. I'm Jessica Eccles, and I work in an adult neurodevelopmental service diagnosing ADHD, autism, and Tourette syndrome, which frequently co-occur together. I trained as a liaison psychiatrist, so that's brain-body connections, and I co-lead in Sussex the world's first neurodivergent brain-body clinic. More about why in a minute. I also have a role, but I am not speaking on behalf of them. I am the chair of the Royal College of Psychiatry's Neurodevelopmental Psychiatry Special Interest Group, which means I convene interested clinicians working in the ADHD, autism, and neurodevelopmental space in the UK, and we try and change education and policy and practice. And I'm patron of a wonderful Sussex-based but now international charity called SEDS Connective and the Sussex charity ADHD Aware UK. So I'm going to talk to you to what Henry has been speaking about, which is basically how we find ourselves in a culture war. And I want to explain to you why I think those narratives are not well informed. I'm going to talk you through what I consider to be the big idea about brain body connections in neurodivergence, a little bit about the flip side, and some reflections on typicality. And then I will thank by saying thank you, and then we'll be followed by Sam. And I have to say, I have the pleasure of diagnosing Sam, and you can watch that on Channel 4. Sam Thompson is that ADHD. So I've explained who I am. So I'm a medical doctor, but I'm also a researcher. So I have a PhD, and I am a specialist in brain-body links and ADHD and autism. So for me, in our very busy, very small NHS service, I am seeing adults, and I mainly see female patients or non-binary patients. I mean, that might be because of being in Brighton, but I think it's also because these are the types of patients that are not diagnosed in childhood. Many of my patients have a substantial psychiatric history. They also have features that suggest that they might have dyslexia, dyspraxia, which is called developmental coordination disorder, or dyscalculia. And that may be things like difficulty learning to tie shoelaces, difficulty holding a knife and fork, difficulty learning to swim or drive, problems with reading and writing, and numbers. And often they have many, many psychiatric diagnoses. So things like eating disorder, depression, anxiety, OCD. They may have been diagnosed with emotionally unstable personality disorder. There may be a query of bipolar or psychosis, trauma, and complex PTSD. Many of them have body focused repetitive behaviors, and they often have a complex physical health history. And because our service is under such demand, we are often only seeing the most risky and the most unwell patients. And it is shocking to see how neurodevelopmental features in autism, ADHD, and in Tourette's, which we so rarely think about, interplay to shape risk profiles in mental health. So, what have we learnt over the years from clinical practice and research? Basically, what we think about neurodivergence, what I learnt at medical school about neurodivergence was probably very wrong. That basically what we thought of as a male condition, these gender ratios are probably 1-to-1. Many key elements, particularly in ADHD, are not captured well by the diagnostic criteria. So, as we all know, ADHD is not really a deficit of attention, it is a problem with switching attention. And people with ADHD often hyperfocus and struggle to maintain attention on more boring tasks. But the real thing is ADHD, and this was kind of been debated as whether it should be in the original diagnostic criteria, is really a problem of emotion regulation. Sorry, I'm battling a bit of a virus. And also energy fluctuations. And co-occurrence is the norm rather than the exception. So we know, and estimates vary, but probably at least half of autistic people have ADHD and vice versa. So really, when we're designing services, we must consider, surely it would be more efficient to assess for both conditions at one time than have separate pathways. And basically, not only does ADHD co-occur with other neurodevelopmental conditions, but it does with certain physical and mental health issues. And although we may get stuck in arguments about, is the population prevalence of ADHD 4 or 5%? What we know is that wherever there is complexity, wherever there is difficulty, wherever there is challenge, there is more likely to be neurodivergence. So the current overdiagnosis narrative has really been at the fore this year on both sides of the pond. But here we are surrounded by articles saying that basically the number of people with chronic conditions is soaring. Are we less healthy than we used to be, or are we overdiagnosing illness? Are ordinary life experiences, bodily imperfections, and normal differences being unnecessarily pathologized? One doctor argues just that, and that particular doctor has been all over the press. At the same time, in the same moment, our government is wondering, are mental health conditions overdiagnosed? So this overdiagnosis narrative, which you could read about in the book about it, if you wanted to pay the money for it, suggests that modern medicine has created an overdiagnosis epidemic, where expanding diagnostic criteria and cultural expectations are pathologizing normal human variation, that this is potentially causing more harm than good. And there is a general suggestion in this overdiagnosis narrative that diagnoses like ADHD are in fact a sick note for life. But what is really important is to notice where this is coming from. Is this coming from clinicians who are experts and trained in ADHD and doing research in ADHD space? No. It is coming from people who have observed ADHD but are not necessarily specialists in it. And I'm going to talk you through why this might be wrong. So there is this idea, the central argument is that there is creep, and also consideration of terms like mild ADHD. If you look in the diagnostic criteria, there is no severity specifier for ADHD. You either have it, and you have it on the basis of a set of symptoms and characteristics and functional impairment, or you don't. There is no mild, moderate, or severe. But research indicates that these increases are actually a correction of historical underdiagnosis rather than overdiagnosis. And we know that even if the general population prevalence of ADHD is 5%, that we have only diagnosed and treating a fraction of that. We know that women and marginalised groups have been systemically missed in earlier diagnostic frameworks. And we know that the expansion of criteria may simply be capturing previously overlooked cases rather than pathologizing normal variation. The ADHD Task Force interim report categorically confirms that ADHD is underdiagnosed. What is true, though, is there is a terrible postcode lottery in terms of there is not currently equitable access to diagnosis. So we know that there's basically greater public awareness. ADHD, the number 2 search term on the NHS website, second only to COVID, and that there is increased research, and that what we really need to worry about is not whether 4 or 5% of the population have ADHD, whether it's 4% or 5%, but how we can help the people who have it and who are most disadvantaged and we need targeted focus and interventions. There is also in this overdiagnosis narrative the idea that physical conditions such as long COVID may in fact be psychological. If you wish, I have a podcast on the ADHD Women's Wellbeing podcast where we talk about the relationship between long COVID, hypermobility, and neurodivergence. We've just published, maybe last week or the week before, the follow-up to this seminal paper in BMJ Public Health, where we show that a demonstrable, so categorically demonstrable difference in physicality, the presence of flexible joints, is linked to a 30% greater chance of developing long COVID. So there is this idea that we shouldn't pathologize everyday life, but this perspective actually may minimize genuine suffering and disability. Yes, there are elements of ADHD that everyone experiences, but not everyone experiences them almost all of the time. And research demonstrates that autism and ADHD diagnoses are a fact associated with significant improvements in quality of life, functioning, and esteem. What is the purpose of labels? I was talking to a colleague, a friend who is a doctor about this, and they said, well, everyone's talking about neurodiversity. I said, you are a doctor, you are a researcher. We need labels because we need labels in order to count things. And it is only by counting things that we can realize the scope and scale of a problem and do something to address it. And many individuals report that diagnosis actually provides crucial access to support services, accommodations, and self-understanding that substantially improves their daily functioning and well-being. I have rarely, if ever, met a patient who said, I wish you hadn't diagnosed me with ADHD. So there is also in this overdiagnosis narrative a question about, should we even go looking for things? What will we find if we do? And is this important? Extensive evidence supports the benefits of early intervention across the board. We know that outcomes are better if you get in early. Henry spoke about problems in schools, about problems in the criminal justice system. It is absolutely essential to identify people who need support. We know that late diagnosis is associated with lower quality of life, higher rates of mental health problems, and missed opportunities. And in this overdiagnosis narrative, there is a suggestion that we're even taking it too far in things like cancer. But we know screening programs are a most amazing public health initiative. They reduce mortality, they reduce morbidity. And I will go on to tell us why actually ADHD is associated with mortality. Then finally, the last argument, that diagnostic labels are potentially harmful as identity, that people take on an illness identity. But we know, and we talk to people and ADHD UK ambassadors, everyone attests to the fact that being diagnosed later in life actually provides profound relief, is a pathway to self-acceptance and connection. And we know that adults receiving neurodevelopmental diagnoses report overwhelmingly positive impacts. My patients describe it as transformative. And the neurodiversity affirmative movement argues that embracing these differences actually reduces stigma and promotes acceptance. So in further consideration, why might we need to take this overdiagnosis narrative that is everywhere in the media, particularly based on one book, with such a pinch of salt? Well, this is being written by a doctor, a neurologist who is not a specialist in ADHD. We do know, though, that their specialism, epilepsy, is associated with significantly increased rates of neurodevelopmental conditions. And that is the interesting research condition. Why do epilepsy, ADHD, and autism coexist? We know that this is not, the overdiagnosis narrative is not including the voices of patients and lived experience, and that is absolutely crucial. We know that the overdiagnosis narrative may really be a servant of a political master. If you are saying that a problem doesn't exist, then you don't need to solve it. And this particular overdiagnosis book is based on case studies. Case studies are, yes, they are important clinical perspectives, but they are not robust research evidence. So, following that, I want to tell you about the big idea. And we often think of ADHD as a neurotype, neurotribe, but and people say, oh, you can't say I look like I have ADHD. But actually, the big idea is that mental health and physical health are completely intertwined, and that the current false distinction holds back research and stigmatizes patients. And some of you will have seen on Instagram and other places the idea of the ADHD walk, and I want to tell you why that might be. So this is a list of conditions that are associated with my research interest, which is joint hypermobility. Joint hypermobility is associated with so many things. Flat feet, you can do a lot about that with arch supports. Soft, stretchy skin, hernias, resistance to local anesthetics, thin, papery scarring, Raynaud's phenomenon, a particular issue if you're taking stimulants, all sorts of gastro problems, reflux, gastritis, inflammatory and irritable bowel disease, problems with periods, problems with irritable bladder, problems with short-sightedness, squints, temporomandibular joint pain, clumsiness, proprioceptive difficulties, that's a sense of difficulty about where you are in space, and brain fog. So this is what I'm talking about. This is hypermobility. This is showing you what is hypermobility. So sway back knees, being able to curl your fingers upwards. Sorry, my screen is trying to update, which we were told to make sure that it didn't, and I tried not to, but there we go. So a child sitting in the W position, being able to do a reverse yoga pose. These are all features of a difference in the body called joint hypermobility. Now, you technically, in order to get a joint hypermobility diagnosis, you need a physical examination, but these 5 questions, if you answer 2 or more, it's highly likely that you have joint hypermobility. So can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? Do you consider yourself double jointed? Now, if you don't score 2 or more, this is a bit like doing a COVID test and it being negative. Doesn't mean to say you don't have COVID. If you don't score 2 or more, it doesn't mean you're not hypermobile. You're probably a man and the diagnostic screening hasn't captured you. But it means it's highly likely that you might be hypermobile. And being hypermobile is actually a red herring. It's just a sign of an underlying difference in the cling film that holds the body together. And that cling film is everywhere. And this difference in flexibility is in fact very common, and it can be advantageous. So Simone Biles, Michael Phelps, they both are hypermobile. They both have ADHD. They are both athletes in an absolute class of their own. But hypermobility, because it is a difference in the connective tissue that is everywhere in the body, this is linked to a variety of medical issues, and they cross systems and involve both the body and the brain. And because they cross systems, they're in silos and people don't join up the dots and think about them together. And one of the big problems is that there are so many acronyms associated with it and different diagnostic criteria through the years that I think, frankly, most doctors who don't have a PhD in hypermobility are confused. And I'm patron of SEDS Connective, and they've done this graphic. There are so many acronyms used to describe hypermobility that it's frankly very confusing. And so you either have hypermobility and problems, symptomatic hypermobility, or you just have hypermobility. And what tips someone from just having hypermobility into having problems? Well, that's an area of research that really needs to be undertaken. So this is a hypermobility spectrum, and it's a bit like the spiky profiles you might see in neurodivergence. One person may have some particular problems with dislocations, where joints come in or nearly out of socket, problems with allergies, problems with pain, problems with fatigue, gut issues, problems of standing, so dizzy when you stand up, dizzy, lightheaded, palpitations if you have a large meal or have to feel like you lie down after a hot bath or a shower, headaches, anxiety, and every person is affected differently. We know that if you take 100 people with panic disorder, 70% of them are hypermobile compared to less than 20% in the general population. We showed in the brains of people that hypermobile people have a different sized part of their brain involved in fear. That is the amygdala, and that they have smaller area involved in where you think you are in space, and that their images look similar to those seen in ADHD and autism. We know that people, the vast majority of people with symptomatic hypermobility experience this problem with postural tachycardia syndrome. So the cling film in the body, which is where you get a heartbeat rise of more than 30 beats per minute on standing. This is where the cling film in the body means that when you try and get blood back to the heart, it might pool in your feet. You might even notice that you have pink or purple or dusky feet when you stand up or have a shower. That this means that the heart has to beat faster in order to maintain cardiac output to vital organs like the brain and the heart. And this means that you get this massive fight or flight nervous system response. And we showed that hypermobile children, kind of teenagers, are more likely to experience depression and anxiety at 18, and that was partly explained by high heart rate. We showed that there's this tug of war in the brain in terms of hypermobile, anxious people. The executive center of the brain, the frontal cortex, is not reacting in the same ways that it should, and that the emotional parts of the brain are overactive. This is a pattern seen in ADHD. We have shown that hypermobility is associated with all sorts of physical health, all sorts of mental health problems, and fibromyalgia, so chronic pain, and MECFS, chronic fatigue. We have shown that childhood ADHD and autistic traits are related to subsequent fatigue at 18, and that is because of your levels of inflammation age 9. As I said, we mentioned that hypermobility is associated with increased risk of long COVID, and we know that long COVID seems to be overrepresented in neurodivergent people. Now, back in the day when I was first getting into hypermobility, I read these articles that said that hypermobility was associated with eating more chocolate, and that you were maybe more anxious, and that maybe eating more chocolate was a way of coping with anxiety. There was also an article saying that people with hypermobility were more likely to smoke and more likely to drink. And was this a way to cope with anxiety? Well, I wonder, is it a way to self-medicate and self-regulate neurodivergence? So this Swedish, in Sweden, they have great registries. They looked at all of the population in Sweden and found that if you had a hypermobility diagnosis, you were 7 times more likely to have an autism diagnosis, 5 times more likely to have an ADHD diagnosis, 3 times more likely to have a bipolar disorder diagnosis, and twice as likely to ever have attempted suicide. So what we did in 2022, this has now been looked at 210,000 times. I didn't update the slides. We showed if you were neurodivergent, you were 4 times more likely to be hypermobile than the general population. That our neurodivergent group reported greater physical health symptoms, particularly pain and difficulties with the autonomic nervous system, and that hypermobility explains the link between neurodivergence and physical health problems. And as you can see here, in our ADHD and autism group, people assigned female at birth, more than nearly 80% of them hypermobile, compared to 20% in the comparison group. We have just, this is under review with the British Journal of Psychiatry at the moment. We have showed how in people with a diagnosis of bipolar, nearly 85% of them are screening positive for autism, and for likely autism, and nearly 70% for likely ADHD. I told you that in the Swedish data, there was a link between hypermobility and bipolar. We put this all together, and it seems that there is this brain-body link in that having flexible joints, this difference in connective tissue, is related to mental health problems like bipolar because of ADHD and autism. We have done this, and this is my new PhD student, pharmacist, Nicola led this really groundbreaking piece of work in our trust that was published in the BJ Psych Bulletin. They looked at people with first episode psychosis. We looked at people with first episode psychosis and found that 40% of them were likely neurodivergent, and that the likely neurodivergent patients with first episode psychosis unfortunately required twice as long in hospital, that they experienced the onset of psychotic symptoms 10 years earlier. Now, if ever there is a rationale for getting in and identifying people who are at risk of psychosis, then finding and managing and supporting ADHD would be a really good way to go. We just are going to present this next month at the Royal College of Psychiatry's Eating Disorders Conference. We looked at 3,500 18-year-olds in the Alspat birth cohort. So that's all the children born in Bristol and Avon in the 1990s. And we see those with probable eating disorder age 18, that this was related to autistic traits at age 7, interacting with ADHD traits in the presence of joint hypermobility, which can lead to gut problems. And you can see that autism and ADHD converge to lead to the development of eating disorder. We've just looked at people attending A&E in crisis, in a mental health crisis, and found that nearly 4/5 of them are likely autistic. And even if we use the most conservative estimates of that screening measure, at least half of those people are autistic, and that there was a correlation between that and joint hypermobility. Unfortunately, we didn't look at ADHD, but I suspect if we look at ADHD, we would have found exactly the same. So do you remember I said that hypermobility was associated with an increased likelihood of ADHD, autism, bipolar disorder, and attempted suicide? You must be thinking, well, how do you get from having flexible joints to being more likely to attempt suicide? And this is the elephant in the room. Suicide is one of the leading causes of early death in neurodivergent people. And autistic people are at least 7 times more likely to die by suicide. Psychosis doubles the risk of suicide. The rate of suicide in bipolar is 20 times greater than in the general population. Adults with a history of eating disorder are nearly 5 times more likely to attempt suicide. This study published this year shows that adults diagnosed with ADHD have shorter life expectancy, that on average, people with ADHD die 9 years earlier. Now, myself, in my college role and with my colleague, Dr. Ulrich Müller-Sedgwick, we are part of the clinical reference group that feeds into the ADHD task force. We were in a meeting. Henry was, in fact, in this meeting too, where we were talking about ADHD and suicide. I found that conversation really interesting. Obviously, from a research perspective, it's very hard to measure suicide. It is a rare event, and most people who die by suicide do not fill in questionnaires before their death. So Ulrich and I were talking, and we thought, well, could we look at self-harm? So I sent this text to a friend and collaborator. So once a month, I have a really boring meeting. That's not the ADHD task force meeting. I mainly zone out and do some stats instead. Yesterday, I was in an interesting meeting for the ADHD task force looking at ADHD and suicide. So today in my boring meeting, I decided to look into it in the birth cohort. Wow, autism age 7 predicts self-harm at 18 because of ADHD traits, and this effect is more than double in those with symptomatic hypermobility. Mind is slightly blown. So this is the diagram. So this is looking at 3,400 18-year-olds. This is particularly looking at women, females. So autistic traits age 7 and ADHD traits interact for the presence of self-harm at 18 with hypermobility. Now, you might be thinking, this is observational data. We've done some really interesting experimental medicine, and we looked at people with pain and fatigue and people without pain and fatigue. And we looked to see, not at their genes. I don't think we're going to find a single genetic cause for ADHD or for autism or for hypermobility. We do know they're heritable, but what we found was that there were, interesting differences in things like mitochondria in the pain and fatigue group, but that the hypermobile group, remember the difference in connective tissue, that the translation of the genes, what that fingerprint looks like in the cell, if we put that into a database to see what other conditions it looks like an autoimmune condition. It looks like lupus. It looks like dermatitis. It looks like eczema. And then we throw in an inflammatory challenge and we upregulate inflammatory pathways. It looks like ADHD. It looks like substance misuse. It looks like heart disease. It looks like bipolar disorder. So this is really suggesting that there is this gene environment interaction whereby a bendy body and the environment and genetics all intersect to lead to situations like ADHD and autism. So that's been quite a heavy and heavy roundup of the research that we're doing. So I wanted to just make a note on strengths. I was approached by a film director. He made Calendar Girls and Maiden Dagenham, and he said he thought the film industry and the creative industry was top heavy potentially with hypermobile neurodivergent types. And we found we wanted to see if this was the case in the general population, and we found that indeed hypermobility was linked to creativity because of ADHD traits, because of neurodivergent characteristics. We looked in, we spoke to 10 people, we did in-depth interviews, and we found for them being neurodivergent was a means of expression. It was a means of communication. A means of creativity was a means of communication and hyper focus. It was a means of combating isolation and improving emotional regulation. Creativity was a means of thinking differently and a way of finding value. So why is it important to think body-brain? Well, we know that nearly half of neurodivergent individuals feel that their treatment of mental or physical health symptoms is worse because they're neurodivergent. Our involvement work tells us that people struggle for years to get an assessment and diagnosis for both mental and physical health problems, that they feel a strong sense of being dismissed, misbelieved, or overlooked when interacting with professionals and institutions. They repeatedly encounter poor understanding and few or no adjustments for their needs within healthcare and education. And why this is going to be really interesting in the future is we published this, a model linking emotional dysregulation in neurodivergent people to the proprioceptive impact of joint hypermobility. Proprioception is the sense of where you are in space. And we showed that having neurodivergent characteristics was associated with emotion difficulties, partly because of a sense of uncertainty about where you are in space, and that effect was double in hypermobile people. Hypermobile people are more likely to experience coordination difficulties. And maybe improving proprioception may improve emotion regulation in neurodivergence. That's research that needs to be done. So we have articles coming out soon on bipolar, eating disorder, self-harm, and mental health crisis. And I just wanted to say a final bit about spiky profiles. Everyone is different and people are dynamically challenged at different points in their life. Do you struggle with socializing? No. After years of intensive study on things like body language, tone, facial expression, eye contact, and psychology, whilst also observing and copying my peers, I have created an adaptable script to follow. I am good at socializing. Can I socialize with large groups of people? Yes. Do I need bed rest from physical and mental exhaustion after socializing? Also, yes. I think this is how the biology, the brain-body interacts with neurodivergence and pain and fatigue and masking. And now we all, as doctors, as clinicians, as policymakers, we need to look to ourselves. If you were in the gifted and talented program at your school in the 90s, how's your ADHD, high-functioning anxiety, and perfectionist-based procrastination going? Bonus if you are also the oldest daughter. Kids who grew up academically gifted are now anxious adults who have thousands of abandoned hobbies and spiral into self-hate whenever they make basic mistakes, or they are doctors. There is no in between. We know that ADHD is as heritable as height. I had the pleasure of representing the college in the BBC Archive Hour, Trouble Staying Still, ADHD's Identity Crisis. And in that, we interviewed my mother, who is late diagnosed ADHD, diagnosed at 72. I'm just going to, I don't think you'll hear this, so I'm just going to stop that. So this is my mum. Wonder how I became articulate, bendy, and ADHD all at once. Listen to me interview my mum on BBC Radio 4 Archive Hour. And this is my school report, which may be familiar to some of you in the room. I'm delighted that Jessica continues to enjoy life at school. She brings a lively intelligence and humour to every activity. This is about age 12. As some comments here suggest, she must resist any temptation to lose concentration or rely simply upon her native wit to see her through. My geography teacher, Jessica's originality borders on the eccentric. So from social media, it's crazy how if you get good grades, they just let you raw dog ADHD your whole life. So to the ADHD is out there, strengths, works well under pressure. Weaknesses, doesn't work otherwise. Shout out to everyone who simply cannot work at an even, steady pace and instead facilitates between frenzied hyperwork mode and a near catatonic state of existential dread and avoidance. When the job requires creative problem solving, the ADHDs are summoned. We need creative solutions to a very serious crisis that we have in this country at the moment. And we need neurodivergent people to lead this and to help this. And I wish to say autism is a lifelong condition often characterized by an inability to bullshit, a pathological need for fairness, a compulsion to help others, an inexplicable need to expose hypocrisy, an excessive tendency to let other people be. There is no known cure. So there's been a huge amount of people who have been involved in the research that I'm presenting to you today, but I have to say a particular thank you to Professor Kevin Davis and Professor Hugo Critchley and Lisa Quat, and also to Sarah Garfinkel and Dr. Charlotte Ray, and to Lisa Page and Nigel Cole, who inspired the Creativity Project, and a big, big thank you to Rebecca Dew at Sussex Partnership, who is our amazing nurse consultant. And a huge thank you also to Jane Green from SEDS Connective. So, and all of the thousands and thousands of participants who have taken part in our research. Now, if you want to find out more, please follow me on Instagram, on Blue Sky, and I have lots of webinars and resources on Linktree Bendy Brain. SEDS Connective have excellent resources for hypermobility and neurodivergence. If you're wondering about what to tell your GP about hypermobility, please do check out the EDS UK GP Toolkit. And please look at Bendy Brain on YouTube. We hope to be launching the channel shortly. It's Bendy Brain, Dr. Jessica Eccles. And I think that that is it, Henry.
Absolutely extraordinary. You're both you and the presentation. Thank you. Well done for fighting through the lurgy. Yeah, it's definitely going around. My family's all down except me. I've been very grateful. I've not yet. We'll see tomorrow.
Well, I don't know what 24 hours of ADHD will do to your immune system.
Yeah, I know. Well, it could be tricky. I've realised I put an echo on the thing. Right, we've got so many lovely comments, like really lovely comments, and I'm going to read some of them to you. I love the passion of this presentation. Another just saying, wow, thank you for this incredible presentation, so passionately presented. Those are scary statistics, and you've talked about how to get involved. How do we support someone just written, wow, thank you. I just wanted you to tell you those. It's a big deal. Right, I've got a question for you. You're casually in one of those high-to-do places that you hang out. where streeting gets in the lift with you, what do you say?
The ADHD and autism are one of the public health crises of a generation, in that if we could intervene early and support neurodivergent people, we could improve the educational, the social, the physical and mental health trajectories of at least 2 children in every classroom, of a vast number of the workforce, that we could improve the lives of so many people. And I genuinely think that if we join our heads together and we think about this in a creative way, that this can be done even within, the idea that there is no more money tree. But we basically have to be prepared to rip up the status quo. What we have at the moment, the system that we have at the moment, the fact that at this time in June, there was more people than there are living in Manchester waiting for an ADHD and autism diagnosis in England. This cannot continue. We need to come up with creative solutions to ensure that these people get the support that they need in a timely way, that this is equitable, that their assessments are of quality, and that we end the postcode lottery that exists.
And what would you say if he just says, but ADHD is not serious and it's just a path to benefits. People are just, what would you say to him there?
I would say to him that if he better understood ADHD or autism and the physical health associations, he would be able to recognize probably half of the people in outpatients departments in psychiatry, the majority of the people attending A&E, the majority of the people who are stuck in hospital, languishing inside rooms where doctors don't understand what is going on. That almost probably, the top 5 presentations to GP practices are things like chronic pain, fatigue, stomach troubles. That if they actually understood how all of this was interconnected, this brain body type, that we could target support and interventions to people. And that this is basically, and we've written a paper that's about to be published called The Elephant in the Room, Neurodivergence in Psychiatry. People are touching this situation, but they're not realizing that this is neurodivergence, that this is the brain-body implications of neurodivergence. The other thing is that ADHD and autism are huge. As I said, at least 1/5 of mental health team patients are autistic. Probably 40% of them have ADHD. That is even higher for people on wards and in hospitals and attending in crisis. If we must acknowledge and accept that neurodivergence is the elephant in the room. It is here, it is everywhere. It is everywhere where politicians should be interested, and we are not talking about it.
That's where I'm at, to the idea that it's a route to benefits. It's the exact opposite. It's without support. There's huge medical costs for things that otherwise could be very differently, more successfully treated. There are economic damages that, if people understood themselves, they'd be able to frame their life in a way that they could succeed. And so what we're doing is we're in this situation where we are depriving people of support, of the knowledge and self-awareness of a diagnosis, the support it brings, and then blaming them for being broken.
No, and also the thing is, as a psychiatrist who works in a neurodevelopmental service, I have the privilege of prescribing ADHD medicine to people who have a diagnosis. We've already discussed how difficult it is to get a diagnosis, but it is a real ADHD medication is generally safe and effective. It is so it's much more satisfying for me to treat ADHD than I'm sure it is for most doctors handing out other medicines. The number needed to treat is incredibly small compared to other conditions. These are potentially life-changing medicines, but because they are stimulants, there is a huge stigma around them. But they are generally safe. Yes, there sometimes are some risks, but there are risks to antibiotics. There are risks to all sorts of medicines that we use, and we need ADHD. People benefit so much from ADHD medicine. There was a study published in Sweden this year in the BMJ. 200,000 people. ADHD medicine reduced serious problems like suicide, like car accidents, like criminal justice issues by 20% across the board. You would really struggle to find in the history of psychiatry any intervention. This is as good as, if not better than, any intervention that we have at our fingertips. But we need to make sure people get the access. And it's not just medicine, of course, it's all of the other things. It's coaching, it's support, it's reasonable adjustments. But this is within our gift. This is within our remit. We need to make sure that people get access to this.
We had a very careful dance that we had to do around the medication shortages because
Yes,
of the stigma around ADHD. We had to talk.
Devastating. Those medication shortages. I had so many patients whose lives were practically put on hold. GP surgeries and our service that were not in chaos, but the absolute disruption associated with that shortage, outrageous.
It's absolutely outrageous, and then your patients were fortunate; they could talk to you, and you were there trying to solve that for them. But for many, there was no one to talk to. Like in my personal case, I tried to talk to my local service, and I was told, "Yeah, no problem. See you in 2 years."
But the problem is, Henry, the ADHD supply chain crisis is not over. We just keep switching. So we couldn't get this dexamphetamine, so everyone was put on Concerta. Couldn't get Concerta, so everyone was put on Equasim and Medicanet. Couldn't get Medicanet. It's just absolutely, it's terrible, and no one's talking about it. No one's talking about it, and it's a political and health scandal, and caused so much suffering and unnecessary work. I mean, all of the amount of work that pharmacists have been doing trying to help people get drugs, people talking, to their GP surgeries, to the neurodevelopmental services. It is so unnecessary.
It is, and it's made substantially more difficult by the way the system is set up, and so the abilities to change prescriptions, for example, only resting with you, means that you find yourself, well, it would be incredibly hard to meet the need.
No, it's a scandal. And we have to think, what other conditions would this be allowed to happen to? Unfortunately, it happens to mental health conditions a lot. There are shortages of other mental health medications, and also, why are there waiting times for physical health conditions, but there aren't for mental health conditions and ADHD and autism in the same way?
Well, it's good of you to cue that up, because we will be discussing that in our final session with Dr. Tim Kendall, the ex-lead for, the ex-person in charge of mental health for the entire NHS, and that is the absolute topic of discussion around the wait lists. But it is the absolute limits of data on how long people are waiting, and we saw, for example, the task force report was delayed for, just sat on a shelf for months and months and months as the interim one, and that was then released on the same day as the debate on assisted dying.
Yeah, I do think it was barely covered by the press.
That was a. I mean, that's the, for those that in the knowledge. So that's the grid. So there's government runs a thing called the grid, where it decides where to release things, worked on what prominence they want things to have. The ADHD task force was absolutely designed to be buried. Like, you don't release something, a medical report, on the same day as the massive medical discussion on assisted dying, unless you want it not to get coverage, and that's which they frankly achieved. The final report was due in the summer. The summer ended, I think, on the 22nd of September, I think it is. Someone will correct me if I've got that wrong. But we're now out of summer and into autumn. We're now told it's going to be sometime in autumn. But like the fact that, and we know that it's been done, it's finished, and the fact that it's not published is, it's just sad, actually.
No, it's really sad, because it is such an issue, and we've spoken about this, Henry. I actually thought the task force report kind of laid out things in a way that I didn't expect it to be so clear. And this is the elephant in the room. Why is no one talking about it?
Well, you've done a great job this evening talking about it, and also, really importantly, actually arming a lot of people to continue that conversation and to put that conversation to other people and put your points to other people, and so that you have helped arm people for those discussions, because that's what's happening. We are being challenged with, like, it's just overdiagnosis. It's not a big deal. And you
yes, and we have a paper out last week in the British Journal of General Practice called Overdiagnosis or Opportunity, and we lay out these points. So if you go to my Linktree, subscribe to the YouTube. If you go to my Linktree, well, you will find the paper, and use that. Take it, write to your MP.
Do you want to quick remind people where your Linktree, how to get hold of you?
So I'm at Linktree Bendy Brain. It's got all my papers, it's got all our webinars, and it's got importantly the link to the new Bendy Brain YouTube channel.
Nice. Dr. Jessica Eccles, you are amazing. Thank you so much. Thank you for your time. Thank you for your incredible passion and advocacy for. It is extraordinary, and you're fantastic. And thank you for being part of the conference, for your work here today. And thank you so much. And we have to say goodbye.
Thank you, Henry. Bye-bye.